I'm Liza, and today we're diving deep into a condition that affects millions of people worldwide, but is often misunderstood, hiatal hernia. Many patients think it's just acid reflux, but sometimes there's more happening internally. To break it all down in detail, we're joined by board-certified surgeon Dr. Moein. Doctor, thank you for being here.
Thank you, Liza. I'm glad we're covering this topic because hiatal hernias are extremely common, yet many patients live with symptoms for years without fully understanding the cause.
Let's begin at the foundation. What exactly is a hiatal hernia and what's happening inside the body?
To understand a hiatal hernia, it helps to understand the anatomy first. The diaphragm is a dome-shaped muscle that separates the chest cavity from the abdominal cavity and plays a vital role in breathing. There is a small natural opening in the diaphragm called the hiatus. The esophagus passes through this opening to connect to the stomach. Normally, the lower esophageal sphincter, which acts as a valve, prevents stomach acid from flowing backward. In a hiatal hernia, part of the stomach pushes upward through this opening into the chest cavity. When that happens, the natural pressure system that prevents acid reflux is disrupted, leading to symptoms like heartburn and regurgitation.
Are all hiatal hernias the same, or are there different types patients should understand?
There are actually 4 anatomical types, but clinically we focus on 2 main categories. The most common is the sliding hiatal hernia, where the stomach and lower esophagus slide up into the chest and may slide back down. This type accounts for about 90-95% of cases and is strongly associated with GERD or chronic acid reflux. Second is the paraesophageal hernia, which is less common but more serious. In this case, part of the stomach pushes up next to the esophagus and can become trapped. If the blood supply becomes compromised, it can lead to strangulation, which is a surgical emergency. Larger hernias can even involve other abdominal organs moving into the chest cavity.
Why does this happen? Is it something people are born with, or does it develop over time?
It can be both congenital and acquired, but most cases develop over time. Aging naturally weakens connective tissues and muscles, including the diaphragm. Obesity is one of the strongest risk factors because excess abdominal fat increases pressure within the abdomen, pushing the stomach upward. Chronic coughing, smoking, heavy lifting, pregnancy, chronic constipation, and repeated straining also increase intra-abdominal pressure. Trauma or previous surgeries may contribute as well. Essentially, when pressure increases inside the abdomen and the diaphragm weakens, the stomach can begin to migrate upward.
Let's talk about symptoms. Many people assume heartburn is normal. When should someone suspect a hiatal hernia?
That's a very important question. Occasional heartburn after a heavy meal is common, but persistent symptoms are not normal. Patients with hiatal hernias often report chronic heartburn, regurgitation of food or sour liquid, chest discomfort, difficulty swallowing, chronic cough, throat clearing, hoarseness, or even asthma-like symptoms. Some feel full very quickly or experience bloating after small meals. In more severe paraesophageal hernias, symptoms may include severe chest pain, vomiting, difficulty breathing, or black stools indicating bleeding. Those symptoms require urgent medical evaluation. What's concerning is that many patients self-medicate with over-the-counter antacids for years without realizing there's an anatomical problem.
How do you properly diagnose a hiatal hernia?
Diagnosis typically involves imaging and functional testing. An upper endoscopy allows us to visualize the esophagus and stomach directly and check for inflammation or Barrett's esophagus caused by chronic reflux. A barium swallow study shows how the stomach moves when swallowing. CT scans can provide detailed anatomical images in larger hernias. Esophageal manometry measures muscle pressure and coordination. We often combine tests to understand both anatomy and function before recommending treatment.
If someone is diagnosed, what's the first step in treatment?
We always start conservatively unless there is an emergency. Lifestyle modifications are critical. Weight loss alone can significantly improve symptoms. Patients should avoid large meals, eat slowly, avoid lying down within 3 hours of eating, elevate the head of the bed, and reduce trigger foods like caffeine, alcohol, chocolate, spicy food, and acidic foods. Medications such as proton pump inhibitors reduce stomach acid production and help protect the esophagus. Many patients achieve good symptom control with these measures.
At what point do you say surgery is necessary?
Surgery is considered when symptoms persist despite optimal medical management, when reflux causes esophageal damage, when a patient does not want lifelong medication, or when there is a large periesophageal hernia at risk of strangulation. We also consider surgery if there is chronic regurgitation affecting quality of life.
Walk us through the surgical procedure in detail.
Hiatal hernia repair is usually performed laparoscopically, meaning minimally invasive with small incisions. First, we carefully bring the stomach back down into the abdomen. Then we repair and tighten the diaphragmatic opening with sutures. In many cases, we reinforce the repair with mesh for added strength. Most patients also undergo a procedure called Nisenfund application. In this procedure, the upper portion of the stomach is wrapped around the lower esophagus to strengthen the valve mechanism and prevent acid reflux. The surgery typically lasts 1 to 2 hours, and hospital stay is usually short.
What does recovery look like for patients?
Recovery is generally smooth. Patients begin with a liquid diet and gradually transition to soft foods over several weeks. Swelling can temporarily make swallowing feel tight, but that improves as healing progresses. Heavy lifting is restricted for about 4 to 6 weeks. Most patients return to work within 2 to 3 weeks, depending on their job. Long term, many patients report dramatic improvement in reflux symptoms and quality of life.
Are there risks involved with this surgery?
As with any surgery, risks include infection, bleeding, injury to surrounding organs, or anesthesia-related complications. Some patients may experience temporary difficulty swallowing, bloating, or inability to burp. Recurrence is possible, particularly if patients regain weight or resume heavy straining. However, when performed by experienced surgeons, outcomes are generally very favorable.
Let's talk about cost, because that's always a major concern for patients.
Cost varies depending on location, hospital facility, anesthesia, and surgeon's expertise. In the United States, without insurance, hiatal hernia surgery typically ranges between $8,000 and $20,000. Insurance often covers the procedure if medically necessary, but out-of-pocket expenses depend on deductibles and copays. Patients should consult directly with their provider for accurate cost estimates.
What is the long-term outlook after treatment?
Most patients experience excellent symptom relief. However, maintaining a healthy weight and avoiding excessive abdominal pressure is essential to prevent recurrence. Chronic reflux should never be ignored because over time it can lead to complications like esophagitis or Barrett's esophagus. Early diagnosis and treatment provide the best outcomes.
Doctor, what is your final message to viewers?
If you are experiencing persistent heartburn, chest discomfort, or regurgitation, don't assume it's normal. Seek evaluation. A hiatal hernia is treatable, and early intervention can prevent complications. Whether treatment involves lifestyle changes, medication, or surgery, the goal is restoring comfort and protecting long-term health.